You're here for the Abramson lecture. Paul D. Abramson was chair of this surgery department from 1951 through 1959. This hospital system has its roots in a charity hospital system. The state gave $10,000 to construct a two-story hospital down kind of where Herbie Cayes is now. How many people know where Herbie Cayes is? Yeah, I figured as much. And that's where the first hospital was. It was a charity hospital for indigent care. And it was so successful that after 6 years, they built a bigger one and relocated over where the Shreveport Municipal Government buildings are on Texas Street. It has a storied past, one wing burned down and things like that. But ultimately, they decided to build a hospital here on this site. And in 1953, during the time when Dr. Abramson was chair of the department, that's when Confederate Memorial Medical Center was constructed adjacent to this medical school building. It was called the Confederate Memorial because it was funded by a Confederate Soldiers' Widows Fund. And there weren't any Confederate soldier widows anymore, and the money was given for the construction of that hospital. And I guess the reason that Dr. Abramson would be considered an icon among us is because he was there at the right time, in addition to the fact that he was a special guy. And he and Dr. John McDonnell actually are the iconic figures that have benefited people like you and me who have come along and shared in the future of our surgery department. So Dr. Abramson was very special. His picture hangs, and I really feel like maybe that picture was painted from a photograph or something, because it wasn't there when he was alive. He was long since gone by the time he got his picture hung. But we're the beneficiaries of Dr. Abramson's foresight. The 1953 is when this hospital was built, but it was in the 70s when it became a university healthcare system instead of a charity system, when it became LSU, Health Sciences Center. So we have a guest speaker today, the Abramson lecturer, and I'm going to have Dr. Mancini introduce Dr. Tribble, if she will.
Thank you. I have the distinguished pleasure of introducing our Abramson lecturer today. Dr. Tribble and I actually go back to residency days. Even though we didn't do our residency together, we crossed the lecture circuit and the paper circuit many times in our younger years. He is currently professor of surgery at the University of Virginia at Charlottesville. He began his medical school career at Vanderbilt and then went on to do his general surgery and cardiac surgery residency at the University of Virginia with a 2-year post-residency research fellowship in the Department of Physiology there. As with most academic careers, he was in Florida for a while and then the University of Mississippi, and he has had many positions, including section chief of cardiac surgery, program director, vice chair and chairman of the Department of Surgery at the University of Virginia, and assistant dean for medical student education while he was at Mississippi. He has numerous accolades, many honors. I think I counted 18 or 20 teaching awards in his CV. He was a National Merit Scholar. He's a member of the AOA. And his professional memberships include the American Surgical Association, the Southern Surgical, and he's one of the directors of the American Board of Thoracic Surgery. His productive career includes many extramural grants. He has over 250 publications that span a range from surgical education to cardiac surgery to VAD. And today he is going to speak to us on the topic of Give My Poor Heart Ease. Dr. Tribble.
Let me see if I can get wired up here. The way that will work. Telling you guys on the back row to not only stay awake, but also to be sure hear what I'm saying. Let's see here. Figure out how to make this work. Maybe better to do it. All right.
Got it?
I think I got it. So, that's your job first. Can you hear me? Okay. So, I also make sure I get my audio-visual things working here. They're different than what I had yesterday. So I know almost nobody in the room is going to be putting VADs in patients or very deeply involved in that. A few, like John's going to Pittsburgh, and Mary's had a lot of experience with this over her career. And some of the others that, like Larry, have had some exposure to the transplant of heart failure surgery and various iterations, generations of ventricular assist devices. But I thought that I would try to, knowing that the audience mostly wouldn't be people like that, try to add some things about things that I think might show some overlap. First, I've had the great pleasure having been able to spend a little time with each of these folks. They've been shuttling me around town, and enjoyed getting a chance to talk with them. And I was able online to round up a few pictures of your beautiful campus. But these are some of the things I thought I might talk about that are related to VADs, but starting a new program or forming a multidisciplinary team. How do you round up the people you need to help you? And how do you make the environment you're working on, this new program concept, become one that the team is learning and getting better in? And so I have some examples of that, but there are people that are going to join practices. That'll be a type of team, a multidisciplinary team. There are people who are potentially might start a bariatric program or a breast program or a trauma program, other broader general surgical cancer program. All of those now are more and more multidisciplinary, more and more require interaction in formal and informal ways, and require that the team learn, create traditions, get some longitudinal memory about what that group is going to do. So I want to mix in some of my thoughts about left ventricular assist devices, mix these sort of things in. I will say that they're becoming more common, and we'll talk a little bit more about that. So every physician will likely, and even if they don't have one themselves or nobody in their family has a VAD, they may see patients with VADs, and they may need to understand that they have a propensity, for instance, that you might be called upon to help with for GI bleeding. They have to be anticoagulated. They get this acquired von Willebrand syndrome thing. So there's a variety of reasons that almost everybody here will sooner or later encounter some of these patients. And one of the traditions that when I was at Virginia and now that I'm back there is that you could not give a talk unless you use a Thomas Jefferson quotation. This is my favorite quotation. Don't do anything new till I come back. He didn't really say that. But I thought that would be my Jefferson quotation. So given that I did some of these things that I'll describe while I was in Jackson and University of Mississippi, I thought, well, maybe a good quotation from Mississippi would be something from some of the blues singers. And this guy, William Ferris, grew up in Vicksburg and eventually became the best known person in the United States for cataloging the blues from the Delta and around here and around there. And this is the name of his book. It just came out a couple of years ago. And as soon as I saw it, I thought, that's a great title for a VAD talk, right? Give my poor heart ease. So therefore, I included a quotation from a famous Delta Mississippian, Sunford Thomas, that's quoted by William Ferris in his book. William is now, he left Ole Miss, where he was a celebrated professor in this realm, went to Yale for a while, where he set up the B.B. King Institute for Study of the Blues. He's at the University of North Carolina now. So, obviously you're going to use left ventricular assist devices to treat heart failure, right? So, is that a big deal? Well, it's actually the most common reason that a Medicare patient is admitted to the hospital in the United States today. Nothing else is more common than heart failure for Medicare patients being admitted. It's also the only cardiovascular diagnosis that's increasing in frequency. We're getting better at preventing coronary artery deaths and coronary artery disease and things of that sort. But it certainly, and we also have the aging population that we all know as part of our demographic. So we're going to everybody's going to see more and more patients with heart failure, and therefore by extrapolation, we'll see some people with VADs. Anyway, I thought those of you who do your ICU rotations, et cetera, obviously some of what you need to do is manage hemodynamics of one sort or another, and how can you make a heart that isn't working well work better? So basically, it really falls in two categories. You can improve the filling of the heart, or you can improve the emptying of the heart. And I won't dwell on all these things, but you can, if you just glance at them, you can treat pulmonary resistance or pulmonary hypertension, mitral stenosis we talked about this morning. Ischemia makes the heart stiff. There are other ways that you can improve the electrical state of the heart, like get rid of AFib. And then you can improve the emptying of the heart. Everybody knows you can give inotropic drugs, but some of the other things you can do include improve valves, improve the shape of the heart. Of course, the ultimate thing, if none of these work, is you either transplant them or you VAD them. So these are some of those things listed with the drugs, ventricular pacing operations, transplant, or mechanical support. So I've always been interested in heart transplantation. This, the very first heart transplant ever done in a human being was done in about as far as I'm standing from the men's restroom right out in the hall from where my office was in Jackson, and this plaque was on the door. I actually did a heart transplant for the sister of the woman who was a scrub nurse in that operation. And I found it very interesting to talk to her about that operation. That's the subject of a different day, but it was really fascinating to hear about. But get back to the regular everyday stuff. This is something that people really sometimes forget, is that when a patient is, or any of us are offered the choice between slim and none, we often choose slim, right? So when a dying person, for them, transplant or a VAD is not that difficult of a decision. The lion's chasing you, you'll leap on crocodiles to get away. And I dwell on that a little bit because it's not uncommon that patients will show up and you'll be talking to them about such things, and they just believe that, you know, they'll hear all these potential complications and costs and other considerations, and they'll say, everything will be fine, right? No, everything won't be fine. And with any strategy that when you have mortal illness. But here's a problem with heart transplants in general, is they're on the decline. And why is that? Well, part of the problem is this: fewer donor hearts, and the number of donors is decreasing. And there's a lot of reasons for that. The changing demographics are some of that problem. A lot of people have religious or cultural or some kind of objections to being donors. And as everyone knows, there's no presumed consent in the United States for a donation as there is in Europe. Interesting thing. But a lot of people don't know this fact either. A transplant actually will last only about 10 years. And so we tell the folks, you get your transplant, a clock starts running, and you're fairly likely to be dead in 10 years. Sometimes before that, some people live kind of almost forever. They must have some odd, that we haven't figured out yet, immunological privilege. The longest one I know is over 25 years and never had any problem, died in a car accident or something. That's extremely rare. Most of the patients really do or die somewhere around that time, usually from vasculopathy, coronary artery vasculopathy. So there aren't enough donors, and they're declining. And some people say it might be some things like this. Everybody ought to have that cares about it ought to make sure you have your donor card signed or your driver's license designated if you would like to be a donor. I certainly would like to be. What other alternatives are there? Well, xenotransplantation, which would be using organs from animals. And this intermittently gets attention when people think they may have some new strategy for creating a genetically a pig. You know, Jim could say he's got his pigs growing out on a farm, and they've infused some stem cells, and the pig is more and more like him, or he's more and more like the pig, or whatever. But that could happen. But certainly this can happen, and it is. This is Bill DeVries that put the first artificial heart in Barney Clark out in Utah quite a long time ago. Anyway, some of my residents got all wound up about doing a review of what people have done about xenotransplantation, and certainly there hadn't been much that's gone on in the last 20 years or so in this realm. I still think it may hold some promise over time with some sort of genetic engineering. Anyway, mechanical circulatory support is something that is pretty obviously going to be part of the solution going forward. It turned out I didn't know anything about this, but this guy, Tetsuzo Akutsu, is shown with a very famous VAD researcher at the Cleveland Clinic, and this is him as a young man. And Dr. Hardy, same guy who did the first lung transplant, first heart transplant, recruited this guy to the University of Mississippi, where he worked for about 15 years. And this cow, Alice, has a total artificial heart in her, and that cow lived in a research thing that was directly below my feet when I sat in my office in Jackson. Dr. Cooley talked Dr. Akutsu into coming to Houston, and Dr. Akutsu helped Dr. Cooley put this heart in 1981 in a person, kept the person alive for a few days. And then he went back to Japan and founded what I think is the largest cardiovascular equipment company in the world, Terumo. They have their own heart called the Dura heart. We don't use it much in places I've been, but it is used around the world a lot. There's a lot of other options besides VADs. Everybody knows of the intra-aortic balloon pump. This is a thing that works kind of like that, called the sunshine heart. You can put it in so it squeezes the ascending aorta. Some of those things might ameliorate or tide people over for a little while. These are temporary VADs that sometimes are used to support people for a few days, sometimes a little bit longer. But the ones that are coming online more and more are especially this one, Syncardia. This is a total artificial heart. Looks more like that. These are the supportive pumps. So they really are assist devices. They suck blood out of the left ventricle and pump it, or suck it out of somewhere, usually out of the left ventricle, and then pump it back into the systemic circulation. This is an older generation Thortec called a HeartMate 1. This is a HeartMate 2. There is a HeartMate 3 on the horizon. And this is the most commonly implanted VAD in the world right now. There are some other things people can do that are sort of temporary catheter-based things. They drop them through, and this Archimedes screw area is down inside the ventricle. But you can imagine that didn't work out very well for very long. They move, they get caught in the valves, they get caught in the trabecula, the ventricle. They don't work very well. I've not ever had a really good experience with one of those things. Usually my main experience with them is taking them out after some cardiologists put them in. I don't blame them for trying. They do work sometimes, but they're not stable. These are some others. These are some for kids. These are some ones you can put in through the left chest. There's a pretty wide variety of them. This is the second most popular one in the world, called a heart wear valve. And it takes a little less space in the chest and has a little lower profile, smaller drive line. It's becoming more popular. It has its own set of problems, different sort of anticoagulation strategies that have to be used. But the real future, I believe, is not just for bridge to transplant or temporary VADs, but destination therapy. I'm not sure I like that term. It sort of reminds me of kind of the discussion about death panels, is grandma's shovel ready or something like that. Destination therapy doesn't sound good. But it's permanent. It's permanent therapy. It's the idea that you're just going to live with your VAD from now on. And it's a little harder at the moment. It was harder when they were bigger. They would extrude sometimes. Everyone still has to have an extension cord coming out of their side. But my kids told me I had to put this in here. Y'all might remember that we had a little music from this movie yesterday. But this is The Rise of the Machines is the name of that movie. We are here, we are waiting. That's where this Jim Fang's title comes from, the New England Journal. But you can't see these graphs very well, but it just shows that this is a continuous, these are survival over time, 24 months, 2 years. The continuous flow of VADs, the ones we're talking about, they just look better and better compared to the pulsatile flow ones or to medical therapy where people die off pretty darn quickly. So again, choice between slim and none. And so more data like that. So I think to make the case that we all need to keep our ears to the ground is, that was one of the first pacemakers put in Minnesota. This is a time when they're doing congenital heart surgery and they often have heart block. So this little kid has these wires coming out of his chest to this external device. How do you think that's going to work out at the playground, right? Catch that thing on the handle to the swing set or sliding board. But here we are today. That's what a pacemaker looks like today. Batteries last 5 to 10 years. Great advance. Same thing with AICDs. These are the kind of AICDs we were putting back in the 90s. It required a sternotomy or thoracotomy. It put these around the heart, and now that's an AICD. Well, that's not hard to imagine as you think about how things keep getting smaller and smaller. That VADs are getting smaller and smaller, and so the day will come when not only are they small and the size of, maybe not the size of those pacemakers, but as far as the burden to the patient for having them, it'll be more like that. And you could imagine that the real key to making them as user-friendly as they'll probably get is transcutaneous transmission of energy. So you don't have to have your extension cord coming out of your side. And that is not ready for prime time, but it's getting close. And there's a lot of work being done in some places. Louisville is one place where they're making some great strides in that regard. So I want to talk a little bit about starting a new program. So when I arrived at the University of Mississippi, I had started a VAD program at the University of Virginia, but they did not have a VAD program there. And so we had to start from scratch to start this up. So I think that the pattern of this has lessons in it that make sense. And so one of the things that is required, I think it used to be that Kevin would like this language. There are things in ACGME that are suggested or should or may, and there's things that must is a different word. And it used to be we should go somewhere to learn how to put these devices in. And when I started the program in the early 90s, with the bigger VADs, I actually went to this same place, Columbia University, and the young attending who had just finished his residency when I showed up there to put a couple of VADs in cows was none other than the famous Dr. Oz. He seemed a little more sane then than he does now, frankly. I still like him, but he's awfully goofy on TV. Anyway, we took our whole team back here, not 20 years or whatever it was later, to Columbia, and there was some other young people whose job it was to teach all of us how to do this. So we had our entire team. We had all the perfusionists, nurses, surgeons, anesthesiologists, and heart failure cardiologists to go together to spend about 3 days learning what we needed to know, and some of us knew more than others, but it ramped the whole team up to a certain level. The second thing is, once I got started, is I mentioned this a little bit in my talk yesterday, you want to have a good circle of friends. Now, some of y'all might know some of these people. Gene Perino is the chief of cardiothoracic surgery at Oxnard, was one of my favorite residents. John Kern is the chief of cardiothoracic surgery at UVA, is also one of my favorite residents. Matt Toole was at MUSC until recently. Actually, I've known him since he was a medical student and trained in general surgery at Emory. And Chuck Claudel is the University of Florida, one of the smartest guys I know about VADs. And I worked with him very closely when I was there. I learned a lot from him. As I started this program, one of the things I did was I would call these guys and say, I thought I had this all figured out, and there's something about this or that or the other I don't understand. And you need to have people in your life, all your lives, that you can trust, that you can call any time of the day or night. They won't get mad at you. You can trust their advice, and I have other people like that. But these particular 4 are VAD experts and do a lot of the work. And among other, Gene in particular, a very colorful guy. It's hard to take these darn things out when you do a transplant. And I said, Gene, taking out the heart ones was easy. Why is this so hard? He said, I don't know, but it is. He said, if the hardest operation you've ever done in your life is a 10, explanting a heartmate 2 is never, ever less than a 9. So it's usually the hardest operation of the month or the year or the day or the week or whatever that you're going to do, which kind of startled me, frankly, but he was right. That is true. So another part of this is organizing the larger group. So besides the core group of people I mentioned that went to Columbia, when we got back, we wanted to be sure everybody in the equation was really on the same page with us. Blood bank people, ICU people, social workers, the finance people, and we had meetings with them. It would fill a room this size. It usually was about 100 people. This actually, anybody ever seen this picture before? It's kind of old now. That's Bob Wallace right there, who was the chief of cardiac thoracic surgery at Georgetown, and that was a patient, typical, somebody who agreed, just had regular routine coronary bypass operation, but he agreed to be this was featured in Life magazine. This is a fold out. So that's the middle of the thing, and there's the folds right there. I remember seeing this some time ago, and then I couldn't ever find it online. I actually paid I paid some young person to go to the Library of Congress and get this picture for me, which they did. But I liked it so much because there are 100 people in this picture besides the patient. And the idea was, even for routine heart surgery, that's about the number of people that have to be, that play some important role, maybe some more important than others, of course, but some important role in that patient's care. And I thought, that's really true in a lot of things. It's true in a VAD program, true in a heart surgery program, true in a transplant program, true in a burn unit, a lot of places like that. Some more prominent roles than others, of course. But I knew we had to get all these people together and to talk to them about it. I'd done some other things kind of like that. I started a living donor lobar transplant program for children when some 15, 20 years ago at UVA. And before we did our first one, we got everybody in the room and we said, this is the first time that we are going to do an operation where we could kill 3 people. And we had those of us who were going to put the lungs in for the child on one side, and we had the 2 other groups on the other side, and the 2 adult males were donating, one left, one right lower lobe. And we all marched through everything we were going to do, including preservation, including the techniques of repair of the bronchi. We took them out, which would be different from a cancer operation, et cetera, et cetera. But I think when you start something new and you have a big group like this, you should get them together and talk through it, listen, and just say we're not leaving until everybody's questions are answered, everybody's comments and suggestions are heard. But also to say to them, whatever we decide and whatever we do, we're going to learn some stuff as we go. And we want everybody to be involved in with easy means of communication, email, suggestion box. You want to say something you thought was cross and you didn't want your name to be on the email, you could put it in the box anonymously. But you want to get that feedback. And it was surprising sometimes to me how there were things out in the interstices of the system that we hadn't anticipated that were real issues. There was something that really wasn't going to work well, and we worked our way through them. So one of the things everybody hears about these days is checklists. The first time I ever heard about a checklist when I was a little kid, that's my dad right there. And only 2 times I ever got to hang out with my dad was he'd take me to the hospital once in a while, and this is his plane. And he had been in the Air Force. He liked to fly planes. I hated planes. I hated heights, but I thought, this is the only time I was seeing my dad. So I'd go fly around that stupid thing with him. He nearly killed me about 3 times. But one of the first times I was sitting there, he hands me a laminated card. It looked just like that. And it had, I remember like it was yesterday, it had 14 things on it. And he said, I want you to read this card to me. I said, okay. And he said, why do you think I want you to read this card to me? And I thought, I don't know. He said, do you think I can memorize and remember 14 things in a row that I got to do to make sure all the radios work and all planes have 2 electrical systems. You got to test them so they're both working before you take off. I said, no. He said, that's right. No one can remember 14 things. Well, a few idiot savants can do things like that, but most of us regular people can't do that. So you can remember 3 things at a time. Some people say you can remember 7. I'm not sure that's even fair. You can remember 7 numbers. Like that's why phone numbers are 7 numbers. But anyway, you can't remember 14. So we worked hard to put together a checklist for each part of the thing that everybody could look at and think about, and then we edited them and got them better. I had some experience with this. We rounded up some of the systems engineers when I was at Virginia. We started doing, this is actually, even though it's called surgical endoscopy, it was about cholecystectomy in the early days. And we were looking at checklists to say, it was a CO2 insufflator. I mean, I didn't do it. This guy, Forrest Callan, is a trauma surgeon still at UVA actually, but he was a resident when he started all this work. But we really figured out how to use checklists, showed their value, figured out how to make them better. But once you get into that mode, and all of y'all are more used to that, you have to pre-out checklists, things like that. But one of the keys is to make it get better over time. This is one of the checklists I put together, and I had it standardized, and I would keep this form on my computer. It's a Word document, and it would start off with the usual things. I mean, sometimes it was a different operation, but for a VAD, I'd say who's going to be there. I'd always put the resident's name if they were there, the patient's name, so everybody could look up their information, was a redo or not, what type of VAD we're going to use, all these other, it was a lot longer than this, but it was easy for me to check it off. I could do this and email it to our entire team in probably about 3 minutes. So it wasn't a burden to me. They could look at it. They pretty much would know what was going to happen. But if there's anything unusual, like if I wanted to do, for instance, femoral cannulation instead of cannulating the chest, I had to have a different set of cannulas. I don't want to get in there and say, oh, we're going to do femoral cannulation. So we don't have one of those cannulas, right? Or we didn't pull it, or it's not sterile, or something. Want to be ready. These types of operations, most cardiac operations are like this. They require a lot of people. There's virtually always 12, 13, 14, 15 people, maybe not always all in the room at a time, but they're in and out. But a good many of them are there. They have to be people preparing the VAD on the back table. Here we are opening a chest, but that's my favorite heart failure cardiologist. And one of my friends said, why is he reading something? Doesn't he know all that stuff already? You're reading a checklist, So I think this person might have already been on a temporary VAD. It looks like a Centromag sitting there. But anyway, there's going to be a learning curve, right? Everybody knows what learning curves look like. You're clueless. You don't know what you don't know. And you sort of get naively confident. You get better, and then things don't. You begin to realize that maybe things aren't as tight and right as you wanted. Become discouragingly realistic when you realize you don't know everything. But eventually, mastery is achieved. So when you're starting something new, everybody's going to go through these kinds of things. Well, what do you need? Y'all know this. I can't remember. Is this E-Trade? This is one of those. This is from one of those commercials. This is the baby that's so funny. And one of the punchlines is he gets banished to his crib. And then the final thing on the advertisement is a man alone with his thoughts. But I think people have to always be thinking that there might be a better way to do things. And I think people have to reflect on what they're doing on real time. I don't mean necessarily, of course you do it in real time, but I mean immediately after operations. We talked about this a little bit yesterday, the value of actually writing things down. And I'm a staunch believer in that. And I have a million of these Moleskine books. In fact, the first thing I'll do when I get back to Virginia is have orientation for our new cardiac thoracic residents, and I'm going to hand each one of them a pretty cool pen and their own Moleskine book, and I'm going to say, this is the single most important educational device that you will ever own. And it'll only be educational if you write in it. So reflect on what you do constantly. Have to do that. You can't just sit there and think you're going to passively soak things up. Anyway, sometimes you have to get off on some different tangent to adapt to other things that come up. And it turned out one of our problems that we had, y'all might have some similar problem, I don't know, but Mississippi Medicaid is challenged by the amount of money they have. That's not new news, really. I actually came to think that the people who ran it were saints and angels. I never, ever talked to one of those people who wasn't working night and day to do the right things for as many people as they could. But one of the things that was a problem was when you have some high-end therapy, they're miserly. They have to be, because one person on a VAD might take away care from an entire quarter of a trauma system or something. I mean, it's expensive stuff. So one of the things they told us was that the Medicare patients could not have the implantable VADs because they thought it was too expensive. So we said, okay, we'll just try and see if we can figure out some other way to use a temporary VAD. So this is what this is. It's called a Centromag. There's a really neat guy from Greenville, Mississippi, who had been a defensive lineman in his high school days and was sought after as a college player, but developed heart failure. So he was one of those people. We figured out a way to put these VADs in through a right thoracotomy, and then lead the tubes. You can't see them in these guys, but they lead the tubes out of their side so they can walk around. This guy, he had this VAD in place, temporary VAD in place, coming out tubes out of his side for over 6 months. He learned how to run the VAD. He would take his flashlight and call and say, "Curt, I think there's some clot in my line. I need more heparin." He would go outside with his jam box speaker and sit out in front by the flagpole in front of the hospital. He had had regular idiopathic heart failure. This gal right here had myocarditis. We actually thought we were just going to tie her over for a day or two, but she also had to be this was not an expense thing, but we were just trying to keep her alive that night, and we ended up rigging it up the same way. But she went about 3 months with this in place and got transplanted. Somebody wrote a book about her. I was pretty embarrassed about that. They were all talking about every chapter in the book was a miracle that happened, and it wasn't really a miracle. It was a lot of hard work by people working hard. So everybody knows that these kind of things result in some late hours and that sort of thing that sometimes can sap your energy. But one of the things that can give you energy back is getting some people. Kevin and I were talking earlier about, he had given a talk on local TV about the medical center, and he had patients from, how long ago did you say, 20 years ago, that your patients that contacted you that you hadn't even heard from. I think that that's so inspiring, and you got to remember that probably more than any other one thing, sometimes when you're choosing surgery as a career, you think, you got to like the technical side of it, right? You got to figure out if you like that or not. One of my residents, Larry, was at Wake Forest. This guy had come up to us from Wake Forest, and we'd finished an operation, and he was sitting with his back to me, putting orders in, and he had a medical student sitting by him, third-year medical student from the service. Wondered what she was learning. I was just kind of listening out of one ear. I was looking at an x-ray. And she says, "Dr. Robocheski, how do you know if you want to be a surgeon?" And he's writing along, and he says, "You ever been sunburned?" She said, "Yeah, I've been sunburned." I'm saying, "Where is this going to go?" And then he said, "Did it ever peel?" She said, "Yeah, it peeled." Thinking this is getting edgy. And she said, "Did you peel it?" She said, "Oh, yeah." He said, "Did your mouth water?" She said, "Yeah." He said, "You could be a surgeon." So I about died listening to that. But the truth is, we don't get all of our energy from that, just the technical side of doing things. You shouldn't, you won't, and it's not sustainable. You got to get some of it, just like Kevin did when the patients called him after they saw him from 20 years ago, people he cared for in the brain. And one of the things I always tell people when I'm going to operate on them is I want them to send me a picture when they're well again. It's partly because I want them to think about it. I want them to construct the picture. Sometimes they figure out this guy actually had a VAD, huge, gigantic, he's big as those two doors right there. And his name is Charles. And Charles told me he wanted to get duded up, and he wanted to spend some quality time with his wife alone, which he claims had been happening. So I have to say, I personally didn't ask him those questions, but our VAD coordinator, this nurse, did. But anyway, here's another one of the VAD patients back home in Tupelo with her significant other, Andy. These people were nearly dead. This guy just told me he wanted to work in his garden. Sometimes you want to live, sometimes you want to regain a normal life with your family, sometimes you want to do something mundane. But I think there's some value in getting people to tell you that. So shifting gears just a little bit, I think also, even if you don't get a chance to do research on something you're working on, you can still contribute in ways and think about new ideas of devices and techniques and maybe, things that you could write about, a series of patients or a techniques article, or you can sign up to be part of a study. It turned out, for me, there are people in the mechanical and aerospace engineering at UVA, including this guy right here, who he splits his time between being a nuclear disarmament negotiator and working on VADs, because both of those things involve the highest level of rotary devices. The whole way you control uranium purification is through centrifuges. So he knew more about centrifuges than anybody in the world. So he goes back and forth to Geneva and works. Anyway, I got a chance to work with them, and we were thinking about what the heck would be the ideal blood pump. We talked a little bit about how people don't like to hear noises from valves and pumps and things like that. So being quiet, small, durable is good. Don't have to be on blood thinner maybe. We talked a little bit about transcutaneous transmission of energy. But what those guys knew how to do was they knew how to make magnetic bearings, and that is, this is an impella, and they knew how to suspend it magnetically and make it turn with electrical currents so that there were no places where bearings could have stagnation of blood. And they made the drills they sent to Mars with NASA, because there's no lubricant to work in that temperature. They make pumps that are on the Gulf floor that are really deep, that pump up from the wells all the way up to shore, because they can't service those pumps. They never wear out. So they use that same stuff same thought processes to develop these VADs. Anyway, that was a program that that's what we call the program, the Life for program. It has not gone to commercial use yet, but it was fun to be involved in that. I mainly mention it to say, even peripherally involved in that sort of thing it can be fun and stimulating and engaging. They rounded up this guy who was involved in that Barney Clark cart out in Utah, Don Olson, and talked him into coming to the University of Virginia. This is Barney Clark right there, and Bill DeVries in those days when they were working on that, and that was the heart they put in him. But he was involved in that. Really smart guy. Probably spent more time thinking about these VADs than anybody, and it was just a great treat to meet somebody who's that smart. I talked about this earlier, transcutaneous transmission of energy. Mark Slaughter and some of his team there are doing a fabulous job with that. Some of the other, just shifting gears again, and one of the other things about a device like this is that if we really have an ideal pump, with the criteria you talked about earlier, it works, it's durable, minimal blood anticoagulation required, maybe transmission of energy, you're going to put them in more people. People with milder heart failure, people that, right now don't qualify, but they can barely do anything. I mean, you have to be nearly dead before you qualify to get a VAD put in. But, children with single ventricle physiology, they're pretty common actually, and nowadays we can get most of them through till they're young adults, but then they die. So right now, everybody's all, bragging on how the single ventricle kids either used to be transplanted, didn't have many children's hearts to transplant, or they died. Then they started doing these Norwood operations and got some of them to live longer. But basically with single ventricle, it means you don't have a right ventricle to pump through the lungs. So they gradually, the resistance in the lung goes up, the heart fails, then they die. Well, those kids would be a great, and there's more children, there are more adults alive today now, young adults, with congenital heart disease than there are children with congenital heart disease, because they've been successful at the first stages of all this, but the next stage is going to be hard, and there certainly aren't enough hearts to transplant them. So they would be some that could benefit from that. Another thing about expanded use is that something made in vast quantities is cheaper, right? I mean, to make the 1,000th heart mate to when you already have the assembly line going, that just costs $25 or something. So a lot of the money that these things cost goes into the startup costs, the research costs, regulations, things like that. But eventually, if there are greater amounts of use, the cost will decrease, and the more people that are getting them, the more people will work on it, and so there'll be more innovation, and as the devices undoubtedly will become more user-friendly. Y'all know what this is all about? Quality adjusted life years. How much money are you willing to spend for a quality year of life? not you necessarily, but society. And so one of the first ones that was ever sorted out was this one, dialysis. America is for sure, because if you have renal failure, you get 100% of your medical costs covered by the federal government, right? Every single person does. When I was in high school, that wasn't true. There were about 3 dialysis machines in the state of South Carolina when I was in high school. And I remember, it was in the paper, they would say, well, we had the coach at Eau Claire, and the coach at Laura Richland, and the coach at Columbia High. By coincidence, they all 3 have renal failure. Only one of them is going to be on dialysis. The other 2 are going to die. And there were committees, and that lasted about a year before everybody said, we're not going to do that. We can deny health care to people that live in poor areas of the country and not feel too bad about it, so we don't have to look at them. But we can't have that on the front page of the paper all the time. So around that time, the 60s, early 70s, they got the dialysis programs going, got machines working, and this is, I don't have a date on here, this is probably within the last 2 or 3 years, these numbers. So we're willing to pay $8,000 for this quality adjusted life year. It's like, how many years do you get out of it, and how much does it cost? You divide all that out. There's some, I don't remember the exact formulas, but there's some well-established math. But we're willing to pay $50,000 per quality adjusted life year for dialysis. We're willing to pay less than that, actually, for a heart transplant, $37,000. CCU care, when somebody comes in with a bad MI and they're in heart failure and high risk and have to be there for a week, that costs more than either one of them. Amazing. Nobody gets brought in the ambulance with a bad MI that doesn't get all the care that you can provide to them. Left main for coronary artery bypass is a pretty good bargain if you look at it that way. But anyway, the LVADs, even now, are the same price point, I guess you could call it, as dialysis. So the truth is that we're close to being willing to put these in a lot of people as a society when you look at things kind of in that regard, and it'll get even easier if it gets cheaper. Some people deny that this is going to happen. This is a short list of very smart people who didn't see something coming, like Tom Watson, chairman of IBM, said, I think there's a place in the world market for about 5 computers. Or similar to this guy at DEC, said, there's no reason for any individual to have a computer in their home. This is my favorite one. The Decca recording executive that turned down the Beatles in 1962. We don't like their sound. Groups of guitars are on their way out. That was pretty farsighted, right? Anyway, I think that these VADs are going to be, I don't know if they'll be ubiquitous, but they're going to be around, and everybody in this room is going to see them. You're going to likely know somebody that has one. As a doc, you'll occasionally be asked to help out with some of these people, and that will become more likely as time goes forward. So I told you yesterday I'd like you to think about things out. If you'd remember if I called you at 5 o'clock, 4 o'clock, not 5 o'clock, you probably y'all are up at 5 o'clock, 2 o'clock, time that you maybe aren't up. These are taking lessons, I think, from all this. One, these blood pumps are going to be used more and more often. They're going to be increasingly user-friendly, just as pacemakers and defibrillators have gone. Starting any kind of new program is challenging, and there are ways to go about that in an organized way so that you cross the T's, dot the I's, learn what you need to learn, and continue to learn, which is probably the most important thing that I would say about that. Obviously, that work goes on in multidisciplinary teams very frequently, and part of what you have to do is not only reflect on what you're doing, but also, even if it's from a distance, kind of be willing to help with innovation, even if it's just with a good idea or be part of a trial. Now, I want to finish up by saying, I'm not saying that God was a thoracic surgeon, but I am going to say the very first operation ever done in the history of mankind was a thoracic operation. I'm just saying. Just remember that. All right. Thank you for your attention.